Yeah, I'm going through the list. Oops, sorry. I'm going through the list. There are some acronyms like WR033. There is a CMS23. I don't recognize any other names. So it's hard for me to tell, but if there's anyone here, welcome. You know,
Yeah.
we send the invitation every week. If you're too shy to speak up, that's okay. We hope you enjoy the show. And I think we should get going.
Terrific.
Excellent. The
Oh,
topic.
I'm sorry. I realize I'm showing up as Luke Tolis. That's my son's name. So sorry about that.
All right. The topic for this week's discussion is going to be principles of cardiopulmonary bypass. It's a fairly densely packed lecture with multiple objectives, which are listed here. We're going to dive right in by talking about the components of cardiopulmonary bypass. I think we have Bill joining us from perfusion as well. If there's anything, please chime in. But I wanted to break this down, especially for some of the junior residents and fellows, in terms of three components for cardiopulmonary bypass. You have to have inflow, number one, which is comprised of venous, cannula, suckers, and vents. In our system, they're blue, orange, yellow, white, respectively. Next, once you have your venous drainage, this goes to a systemic pump, heat exchanger, and an oxygenator in that order. And then you have the outflow cannula once the blood has been oxygenated, which comprises the arterial cannula and the cardioplegia. This is a scary diagram that everybody always sees, and I actually want to spend like 30 seconds describing it. We can all focus on the blue, and you can follow my pointer. So here is the heart. You have the venous cannula depicted here that goes to a venous reservoir. In addition to the venous drainage, you have your vents, so your LV vent here, your aortic root vent here, and the suckers that all go into the venous reservoir. From here, you then pump this through the systemic blood pump. For our system, it's a roller pump. This then goes to the heat exchanger, which is shown here. This heat exchanger itself is obviously connected to a water source to cool or heat the blood that comes through. Once you pass the heat exchanger, you go to the oxygenator, which is really the powerhouse. The oxygenator can have the blender, the gas flow meter, vaporizer, all of that coming into it. Once you've oxygenated your blood, we'll switch over to the red. And there are really two main outflow mechanisms. One is through the cardioplegia line, which is shown here, that gets mixed with the cardioplegia solution and then goes back into the heart for a cardioplegia if needed. Or the alternative is going through the arterial system back into the inflow line into your aortic or arterial cannula. Based on this system, I wanted to talk about hemodynamic monitoring when we go to the operating room. And here I was hoping to get some participation from the audience. We can start with Brian, one of our interns on thoracic currently. Brian, when you think about going to the operating room in cardiac surgery, what are some monitors that you are thinking about asking anesthesia to put on prior to going to sleep?
You typically want a central line in. You want to float a swan to be able to monitor your right-sided pressures. I believe we use NIRS here, so you're looking at monitoring brain activity.
Great, yeah. So, and then additional ones that I wanted to point out here, EKG leads, pulse oximeter, kind of our standard items, and then arterial and venous lines. Temperature probes, very important, oronasopharyngeal ones, and bladder probes is what we normally have. And then in terms of monitoring BIS analysis for EEG, capnography, and then TEEs are fairly standard. Additional lines that we use, for example, if you have a type A dissection, you want to be thinking about also adding a left radial A line or femoral A lines for descending aortic aneurysms. I've also included a special one for hypothermic circulatory arrest. There you want to add additional A lines based on your cannulation strategy and perfusion strategy. As well, in addition to the nasopharyngeal temperature, you want to have your bladder temperature and know which one is, how they correlate, and use those for rewarming particularly. And then EEG, SED lines, infrared cerebral oximetry, and transcranial ultrasound are all other items that we use. And this is all been reviewed by Dr. Jasser, who uses this type of a hemodynamic monitoring setup for his cases. Next, we can ask Linz, if you have your patient set up, and what are the cannulation strategies that you can think of for the arterial system, venous system, and then what then sites can you think of?
For arterial, I would say aortic and then femoral, and also you can do axillary. For the venous side, you definitely, you can do dual stage through the right atria, bicaval or femoral venous access. And for venting, I think about venting the LV through the right superior pulmonary vein and the mitral valve. And you can vent the aortic root or the pulmonary vein.
Yeah, that's right. So depending on what procedure you're doing, these are essentially all the options that we proceed. I would say most commonly for an aortic, any CABG, for example, you'll have a central cannulation into the aorta, dual stage, and then vents as needed. I want to get into next talking about how to set up an actual bypass run in the operating room. And the way I've set this up is by going through specific steps of the procedure. And in each of them, I'll highlight some important items. Number one will be giving the heparin once you're ready to start the process. And here I want to ask a couple of questions to highlight some important learning points. We can do Andrew, is Andrew Baldwin on here? How much heparin do you give when you're you're telling anesthesia and perfusion to give heparin?
I can answer for Andrew since I'm his equivalent level. So typically the dose is 300 units per kilogram. The perfusionists have a fancy calculation that they do that takes a couple other things into account, but that's the rough guide.
Excellent. So I've depicted that system here, the Medtronic heparin management system, I think it stands for, which is the machine shown here. There's a specific cartridges that they have that have 0, 1.7, or 2.8 units per milliliter of heparin. Once you add the patient's blood to it, it measures your ACT, and we look for an ACT of 450, and then figure out what your heparin concentration should be, and you just multiply that by the patient's blood volume to determine the actual dose to give. It's an approximation. I think for the boards we want to know 300 units per kilogram, but in-house this is the system that they actually use to give you that number. And then, as I mentioned, ACT we're aiming for is 400 or more than 2.7 level. Jordan Bloom, if your heparin level is less than 2.7 or your ACT is less than 400, what are you going to tell the team to do?
Sorry, this brings up two different issues. One, you may not have given enough heparin, and there are reasons why that 300 unit per kilo may not be a good estimate. Part of that depends on, the sort of ideal body weight versus actual body weight. And so usually we'll just give more heparin. The other scenario you can have is this so-called heparin resistant patient. And if that's the case, if you've given multiple doses of heparin and your ACT is still low, then you can consider giving drugs like antithrombin 3 or usually AT3 is the drug that we give to those patients.
Excellent. That's great. So we can do antithrombin about 1,000 units, and then or FFP. And then we usually check ACT 3 minutes after giving a full heparin dose, and then within 5 minutes after starting bypass. And then perfusion.
Let me just interrupt you, Antonia. Always consider human error too. If heparin was actually not given, or if what was given was not heparin. So okay. These are very important considerations. You have to think of them because some old-time surgeons actually used to give heparin themselves onto the right atrial appendage for exactly that reason.
Nice. Okay.
Also, you should pay attention to the number that this machine gives and what they're planning on giving. It should always be around 300 per kilo. Sometimes it's wildly higher or wildly lower. And in those cases, I tend to overrule it and meet somewhere in the middle because the machine is not that good, in my opinion.
I'm going to add a few things as well. So ACT turns out to be more complicated than you might imagine, and this particularly became apparent when people were beginning to use a drug that's no longer used very much called protamine. And when protamine was used, you got very different ACT numbers depending on what kind of ACT cartridge you used. The cartridges are made with diatomaceous earth. This is not a very precise chemical reaction, and so depending on which manufacturer, which source of diatomaceous earth was used, you got very different numbers for the ACT. So that's the reason to look at heparin levels. That was the driver. The protamine story was a big driver for going to heparin levels. The second point to be made is that giving heparin and failing to give heparin is what the nuclear engineers call a single point vulnerability. If you go on bypass without giving heparin, the patient will die. That's it. You're done. Operation's over. You absolutely have to be 100% certain that the heparin has been given, which is what George's point was.
Great, thank you. Once we've given the heparin, the next step is cannulation. We usually commence that once heparin level is more than 2.7, or if the ACT is surpassed the baseline and is rising. Question for Travis Hull. Travis, what does RAP stand for, and VAP?
That's like the $500 question, right?
You can phone a friend, Travis. You don't know?
Sorry, I was on mute. I think it's priming the circuit backwards, like from the aortic cannula. I don't know if the...
Yeah, so retrograde autologous priming through the arterial line, and then antegrade or venous priming through the venous cannula, which are all things that you should consider prior to going on to display some of the volume that you have in the circuit. Excellent. Next, going on bypass, we have a checklist that the perfusion uses that I've outlined here on the upper right of the screen to go on bypass. Once you're on bypass, the things that you want to think about as the circuit is running, and the way I split it up is essentially the venous side and the arterial side. And each of those, you have your body, you look at your CVP, is it close to 0 or negative? Is your right-sided heart fully decompressed? Is the pump working? Is there adequate venous drainage? And then look at the pump. Are you getting enough flow? Are the arterial line pressures not above 300? Look at the aorta. Is there no dissection? And then look at the body. You make sure you're getting adequate maps and adequate oxygen saturations.
What about the shunts? Okay.
Say that again?
Joke.
Guys, the checklist note will not let you go on bypass without heparin. That's the purpose of the checklist, but it will let you cannulate without heparin. And you should have a routine for when you give heparin so that you know, so that you do it the same way on every case and don't forget it. It's easy to forget when you're passing around responsibility from attending to resident back and forth. So there really ought to be a set point in every case where you know to give the heparin.
So for example, I never put the cannula in until I know that the ACT is above the baseline. Never, ever, ever, ever.
That's a good practice.
So Antonia, why would you think, you know, if you don't give heparin and, you know, I mean, if you do ECMO, you don't give heparin, probably the patient will live. And in this case, the patient, as Dr. Sanz said, the patient will die. Why is that? Can you explain that to me?
Well, if you don't give heparin, you're essentially form thrombi. You can form thrombi throughout the entire circuit.
But why that doesn't happen on ECMO? What's the difference?
Why does it not happen on ECMO? Well,
I mean, you might get some clots, you know, you might send some clots, you know, to the brain, but the patient is not going to die immediately. What's the difference?
Well, you're solely relying on the bypass machine to support the patient. So if it goes down,
it's in your picture, Antonia.
Which one? Sorry.
Of the circuit.
What's present in a bypass circuit that's not present in an ECMO circuit?
The roller pump.
The largest part of the picture, probably.
Go back to your
Venous
picture.
reservoir.
Yeah.
Okay.
Yeah. So you have all the blood going to the reservoir, and there is going to be stagnant there, and all the blood is going to be accumulated there and clotted. Immediate death.
Got it. Thank you.
Go back to your checklist again, Antonia, for a second.
Yeah.
So what if when you put the arterial cannula in and they're checking your pulsatility of the arterial line, and your arterial line is 15 points higher than your map? What does that mean?
Yeah, we actually, it's one of the scenarios, if we could save it for later.
Okay, sounds good.
Yeah.
And are you also going to talk about sequestration and ANH? You passed through the RAP and AB.
Yeah, we didn't, that wasn't one of the objectives, so I'm not including anything about ANH.
Got a lot to go through. Let's let her. Let's let her.
Okay. Next, once we've done the checklist, you're on bypass with adequate flows, you can tell anesthesia to turn off the vent, check your PA pressures, apply the cross clamp after asking them to come down on the flows, and then give cardioplegia. Cardioplegia is this whole separate talk that is coming up next, and I just wanted to ask the audience, we can do William Shee, how much cardioplegia are you going to ask them to give?
Morning, Antonia. It varies between different institutions, also varies depending on the route you want to give. Typically, where I've trained in our practice, it would be around 600 mils antegrade and then 400 retrograde. But you can also give 1 liter antegrade for patients, say, under 80 kilos, 1.2 liters antegrade for patients above 80 kilos, etc.
I think the dosing is 20 ml per kilo. I think that's what they use at children, at least at children's.
Great. I've also included this diagram or this chart for you for the reference in terms of the routes that we give it, and then what flow rates you should expect and what pressures you shouldn't exceed.
What setting might you expect to want to give a little more?
Sorry, say that again?
What kind of pathology do you suspect you might need to use a little more cardioplegia, particularly to get the muscle mass cooled?
Yeah, especially if you have concern for hypertrophic hearts, you'd want to give a little bit more.
Antonia, one other point about number 1 there, you said that when you have adequate flows, you can turn the lungs off. It's not just adequate flows, but you also have to make sure that the patient's not ejecting anymore. Because if they are still ejecting a lot and the lungs are off, then you have a shunt and the patient will become hypoxic.
A couple slides for in terms of physiology that we wanted to touch on. Number 1, cardiac output is determined by oxygen consumption. We generally accept a flow rate of 2.4 liters per minute per meter squared. So about 4.8 liters per minute for, let's say, an average person with a BSA of 2. Hypothermia reduces oxygen consumption by a factor of 0.5 for every 10 degrees decrease in temperature. And the way you can think about this is for every degree of reduction in temperature, you can decrease your rates by 7%. This is based on the published data, which is shown here, which is exactly illustrating this with your reference down here. A couple of formulas we should know. Pump flow rate is essentially your index with your BSA, which is your output. This is how you calculate cardiac out or BSA for your reference, and then cardiac output based on oxygen consumption formulas to know. Next, I wanted to touch on the value of oxygen delivery in maintaining optimal flows. We want to aim for a 262 milliliters per minute per meter square indexed oxygen delivery, which is the equation is shown here. That's based on published literatures that have shown that anything less than this is associated with the development of lactic acidosis and acute kidney injury. If you do have lower levels, the thought is you should make sure you have enough venous drainage. You should increase your flows, decrease temperature, or increase hematocrit or transfuse if you can. Final step in before we get into all of the scenarios that I want to go through is a weaning bypass. We have a weaning checklist again included on the right for your reference. But the steps to think about going through: number one, start rewarming the patient. Number two, de-air and remove the cross clamp. I'll have a separate slide for de-airing mechanisms. Three, start ventilating, pacing. Do your checklist, and then gradually clamp the venous line and decrease flow and fill the heart while you're transitioning flows away from the machine. You can then get the venous cannula out and then give Protamine, and then at the end finish off by taking out the aortic cannulas. In terms of de-airing, I have included here preliminary, final, and additional maneuvers. This is one way of doing it. I'm sure other attendings have different mechanisms of this, but if you have a vent or an aortotomy in place, you want to leave volume in, ventilate, tie the knot down, and then get the volume out and stop ventilation. The final de-air mechanism, the sequence is head up, volume in, ventilate.
I think it's head down, Antonia.
Sorry?
I thought you meant to say head down, not head up.
Yeah, what do...
no, Antonia has a sequence.
Yes. I think, Dr. Toles, that's... I've seen both ways done, but if you think about it this way, head up, volume, and ventilate, make sure the white is on and white is up so that the air arises and gets out through the white vent. You can shake the heart, shake the table, ask them to get the volume out and stop ventilating, and then bring down the flow. Cross clamp can come off, and then you can get the flows back up.
May I add one comment?
Yeah.
In contemporary heart surgery, you have a very nice way to detect the presence of air because the air-gas interface shows up so well on echo.
Mm-hmm.
And there'll be micro bubbles that are not visible and don't cause any real pathology. I would just mention as an aside that using carbon dioxide in the field will reduce that, but the places you want to also look is in the dome of the left atrium, because there will sometimes be sort of foam that's accumulated there, and you can very easily and safely aspirate that out with a 25 gauge needle. We used to call the echo anesthesia guys used to call out foam in the dome, but that's a very common place, particularly when the LA is enlarged. I will just add one brief anecdote. When I was chief resident, Bill Daggett did a very advanced mitral stenosis case in a patient that had a giant left atrium. And when we got up to the ICU, there was a circular area of increased density on the chest x-ray. And on the lateral film, there was an air fluid level in the left atrium, and we went back to the OR very carefully, actually in the patient's bed, and took 32 cc's out. So the echo is a very important, and I would urge that people be engaged in looking at the air on the echo as you
But back to the George's point. So every attending does different, de-airing mechanisms. For the fellows, what's important to know is that there is some logic behind whatever attending does. So, for example, what I do head up, volume in, and ventilate so that the air goes into the root, suck on the root, shake the heart, and then level the table or head down. And obviously, before the clamp comes off, you have to have table down or level the table. Some people skip certain things, but as long as the fellows can explain the logic behind what they're doing and how to manage the de-airing, that's fine. A lot of the time, I notice that people don't have structure how to de-air and at what point take the clamp off and all that.
Great, thank you.
You're talking about the head up with the clamp on?
Yeah.
Yeah.
I do that to push the air out into the root, and then after that, after the air gets sucked out from the root, then I level the table or head down, and then I take the clamp off. So it's additional time for the air to go into the root and get sucked into the vent.
I think what's going to be apparent is that none of us have a perfect way to do this, and it's very vexing, irritating problem. Chuck Huddleston used to say he hated air. He wished he didn't have to breathe it.
Great.
Yeah, I agree with Sergey. The only couple additional things to say is that rather than trying to remember exactly what the thing is, in the course of your training, you will come up with a system that works for you. There are some principles that I think most of us will adhere to. One is, you know, filling the heart will displace the air from the heart. The LV vent is not a de-airing vent, so don't think that you're going to de-air through the LV vent. It is meant to suck out volume and decompress the LV. There's a lot of air that is stored in the lungs during the time when the lungs are not being inflated during bypass. So you can get some air out by inflating the lungs. And then head up, head down in whatever ways you're going to vent is individualized. But just remember, you have to de-air. Another place where de-airing is important is that if you've been off bypass for some period of time, but you're still cannulated and you have more volume to give, make sure you check your arterial line to make sure that there's no air in your arterial cannula before you start pumping that back.
Great, thank you.
Let me, I'm sorry again, I know this, we're not supposed to have this to drag on, but the LV vent is a very good de-airing vent. I mean, I don't use it. I only use LV vent in circ arrest cases, but I think that the LV vent is a phenomenal de-airing vent. So I disagree with the statement that it's not a de-airing vent. Just for the residents, to be careful.
What I thought would be consensus, but but you get the idea.
Good points.
Thanks. We can move on to the final point before we talk about some scenarios. Mike, I think, is on the call. Mike, how much protamine do you give at the end of your case?
So you want to give one. Let's see if I remember.
We have the luxury, I found out, of this machine that tells us how much to give. But
yeah, there's a machine, but it's 1 milligram. Yeah, I was thinking 1 milligram.
Yeah, so 1 milligram of heparin given, which is about 100 units, you give 1 milligram of protamine. So let's say you've given 30,000, it'll be about 300. For example, I've included the Horrow classification for protamine reactions, which we should be aware of. Type 1, just transient hypotension, type 2, anaphylactic reaction, and then the third one, which is the most catastrophic, pulmonary vasoconstriction, where you would go back on for us to know. We're going to switch over to scenarios. Luis Tapias is up next. Luis, the way we're going to have this set up is we're going to have a scenario at the top, and then we'll have management or differential diagnosis and then management. If you can give me a couple of reasons you would have inadequate venous drainage, that would be great, and we can get this part started.
So causes for inadequate venous drainage are malposition of your venous cannula, an air lock, which you can deal with by applying vacuum. The wrong cannula size for the patient, body weight and size.
Great. Yeah, so malposition cannula, you can have a cannula that's too small, kink in the line, inadequate drainage, a massive airlock, which I want to go through, and then volume somewhere else, for example, which we can go through. If you have a malposition cannula, you just adjust the position. Massive airlock, there are a couple of steps to think about when this happens. Number one, you can apply a little bit more vacuum if you have a vacuum pump in place. Number two, you can stop the run, separate the venous cannula from the venous line, manually fill the venous line with saline, and then reconnect the two. Also, if there's just a small amount of air, it can be what we call chased back by progressively lifting the venous line to get the air out. The venous cannula are too small, just exchange it or add more vacuum. If there's a kink, you can correct that. If there's inadequate gravity drainage, our perfusion team says that they'll apply up to 60 millimeters of mercury suction to the drainage cannula to see if we can get more out. In terms of volume somewhere else, think about if you're doing femoral cannulation, are you losing volume in your abdomen, for example? Check abdominal girth, get an H&H, and then think about venous tears. And then other sources of blood in the heart, if you have aortic regurg, is there you can place a vent. If you have an azygous vein that you haven't adequately drained, you can adjust your snares. And then if you have a left-sided SVC, you have to think about snaring and cannulating that. Next scenario. John Trahanas, this is you. The heart is not arresting with retrograde cardioplegia.
So probably the most common is that your retrograde catheter is not in place. You need to check the coronary sinus pressures, either manually confirm it, you can confirm it via echo, or worse, you can open the right atrium and just make sure that it's in the right place. Those would be the things that I'd be thinking of.
Great. So catheter mispositioned, cardioplegia solution or inadequate delivery, rupture of the coronary sinus, balloon rupture, or a persistent left-sided SVC. In terms of management of these, for the catheter, you can use the echo to look for it. You can manually feel it. You can check your cardioplegia line or solution. If you are suspecting this, you could just look at the inferior aspect of the heart for the rupture, check the balloon, or try a different catheter. The persistent left-sided SVC, I want to spend a little bit more time on because it was one of the important aims. The thought here is, I actually have one slide that I can just go to. What we're talking about here is this: if you have a left-sided SVC in place, the most important thing related to this is that, one, you may be having additional volume returning to the heart that you are not draining with your venous cannula, for example. And then number two is that when you're giving retrograde cardioplegia, you may be giving it or having an inadequate effect. The distinguishing factor for all of this is if you have this innominate present, which is depicted here with the question marks. If there is an innominate, you can just clamp the left-sided SVC and give cardioplegia. We talked about this last week, but you have to be careful not to get the left phrenic. If there's no innominate present, you have to cannulate the left-sided SVC and to prevent cerebral hypertension. In this case.
Hey, Antonia, I just want to make a quick comment because I did a case yesterday with Dr. Cameron where we had a persistent left SVC with no innominate vein. And we did cannulate it, but we cannulated it a little differently than what I would have thought we did. Initially, we took a 20 French cannula. We had to be in the right atrium anyways to fix the PFO. So we took a 20 French cannula and cannulated the coronary sinus with it and advanced it all the way up into the left SVC, and we're able to use a third venous cannula to have adequate drainage while we were in the right atrium, which was kind of cool.
Nice, yeah, great. Next scenario, this is going to be for Travis Hall. Travis.
One of the points to make about a persistent left SVC is that you only have to worry about it if you're planning to open the heart or planning to give retrograde cardioplegia. The persistent left SVC for a cabbage is immaterial. It doesn't matter. Your dual stage is going to drain everything you need to drain. So don't let that bother you unless it's really going to bother you. For an AVR, you won't be able to give retro, but you don't have to do any of the other stuff. If you really have to open the right atrium, then it becomes a necessity.
Great, thank you. Travis, you have a full heart despite an index of 2.4. What could be some causes?
You have a full heart because of an index 2.4.
Yes.
So, can you hear me?
Yes.
So you have a full heart. So you would want to drop the flow and adjust the venous cannula. I guess you're worried about like an airlock or.
Yeah, it's more getting actually at the point that you have another way of filling the heart. So for example, aortic insufficiency, patent ductus, inadequate venous drainage or left-sided SVC with bicanal cannulation that we talked about before, large VSD or collaterals. For each of these, I've outlined management strategies. So if you have insufficiency, you can put in an event, you can ligate the patent ductus. And then if you have inadequate venous return, you can reduce the flow or add vacuum, reposition the cannulas, as you mentioned. And then we talked about the SVC, a left-sided SVC. And if you have a large VSD, you'll have to repair that. And for the collaterals, venting the heart will be the way to go.
Antonia, a large VSD will not result in the heart not being decompressed as long as there's a vent in somewhere. So I wouldn't spend time looking for a VSD if the heart doesn't decompress. It's the other reasons that you've already listed.
Excellent, thank you. We can go back to William, and give me one reason why you would have LV distension while you're giving cardioplegia.
Well, from aortic incompetence, or it could be from some kind of manipulation that you've caused incompetence of the aortic valve.
That's great. So yeah, number one, if you're giving it and you likely have AI that you may have not caught earlier, you can manage that by giving either retrograde, or if you're going to do an aortic procedure, you can just open it, give osteals, or place a vent to manage that. The next one is a longer one. We can go with, is Andrew Baldwin back on the line?
Sorry, Antonia, to interrupt you again. On your last slide, extremely important, what you said is correct, but extremely important to make sure that your clamp is fully applied, that you're not leaking from the systemic circulation into the heart.
Yeah,
very important point about distension during the operation.
Okay, thank you. That's a very valid point. I will add that to it. Great, so we can high arterial line pressures. If Baldwin isn't there, Luis, you want to take this one?
I'm here. I'm sorry, I stepped out for a minute. I'm here.
No problem.
So high arterial line pressures. I kind of did. Number one, I'm concerned about the potential for dissection. So it depends on where I'm cannulated, but I'd be worried that about my cannulation site. I guess you could also think of other things like the kind of actually the equipment, the cannulas. Do I have a small cannula? Is it high pressures because I have an undersized cannula for the patient? You can have a kink in your arterials or anywhere in the circuit that could cause high line pressures. You could have thromboses, I guess, if you're not properly heparinized.
Great. Yeah.
I'm running out of ideas.
No, that's great. So stay with us, and we'll ask you how to manage a aortic dissection, which is one of the differential diagnoses you need to rule out here. But exactly, if you have an obstruction of the arterial circuit, just check for a kink, or if there's a clamp that was left on the line. If you have a malpositioned cannula, reposition it. If it's too small, you can upsize it. And then one of the most feared ones is iatrogenic dissection, where you would see low systemic pressures, bluish discoloration of your aorta, and an expanding hematoma. And Andrew, what would be your sequence of steps that you want to proceed to manage this?
Manage if I have high pressures or if I have a dissection.
If you have a dissection.
So number one, I'd ask Dr. Sunt or whoever my attending is to come back. But I would immediately start. So I would want to re-access for my arterial circuit somewhere. So if I'm centrally cannulated, I could think about cannulating femorally, and I'd want to get new access and start cooling immediately to start cooling down so I could circle rest.
Yeah, that's
so.
Yeah, go on.
So I would find new access, start cooling. You've already put up secrets there, but I'd watch the behavior of the heart to make sure we knew when we started to fibrillate. I'd want to resect everything, including the cannulation site. You can't leave the cannulation site behind because that's your entry tear, and that's about it.
Yeah, I think that's fantastic. I don't know if the attendings have any other tricks to add. I did not put on here call for help, which should be even. I figure if you're an attending as well, you'd want to have someone to help back up if this were to happen.
The most important thing, Antonia, since you asked for attending's input, is remember not to move to the next step where you can't come back from. So if you go on bypass and you have high resistance, even a dissection, all you have to do is give the volume back to the patient, and you have an alive patient. You can make decisions about what to do next. What you don't want to do is ignore it and put a clamp on and arrest the heart, and then you've gone to a point that you can't come back from. So extremely important that once you recognize that something is not right, immediately give the volume back to the patient from the venous line, not from the arterial. Leave the arterial line in, and then you have an alive patient whose heart is beating, and he can just decide what to do next.
Dr. Tola, just for clarity for myself, so when you mean come off bypass?
Yes.
Yeah.
Yes, absolutely.
Yeah.
You've gone on
Okay.
bypass for 30 seconds. It was rough.
Okay.
It didn't go right. All you've done, the worst thing that you've done aside from the dissection, is remove volume from the patient from the venous
Okay.
line. Just give that volume back.
Got it. Thank you.
Can I also ask a question? There's some discrepancy when you're studying for tests on what to do if you put an aortic cannula in and you get a dissection. And there are some very strong language that says do not remove the aortic cannula, and there are some also very strong language in other resources that says you must remove the cannula. What do you guys think about that?
Do not remove the cannula. Leave it exactly where it is and find some other place to cannulate. And the only way you should look at that cannula is from the inside on circ arrest.
But I guess the question Jordan is asking, and I can see that discussion, is that could you use potentially the same cannula to just keep cooling and keep going on bypass and keep perfusing? Is that what you're asking?
The reason.
No, I think if you have, for example, dissection from the cardioplegia, from the antegrade cardioplegia cannula, then I've seen that you can flow. You can use the same cannula and cool, and then do your dissection repair through the same cannula that you have in the aorta. But if you have a high pressure in the aorta, like George was saying, you give back volume, you leave everything as it is, and you cannulate either femoral or axillary, and you do totally different operations. So it depends where the dissection comes from. If it comes from cannulation, you cannot use that.
And you don't pull it out.
And you don't pull it out.
And then also
now, what Dr. Melnichuk said, if you get a dissection from your antegrade cardioplegia cannula, you should immediately drain the patient once you see that it's dissecting, because the number one thing to do is you can't get the dissection if you don't have a blood pressure. So immediately drain the patient, put a clamp on, because the clamp is going to be between the aortic cannula and superior to the dissection site, and then reflow and fill the patient up and start cooling. So it's different when you get it from the antegrade than when you get it from the aortic cannula.
And then don't forget to do the original operation that you're there for in the first place after you fix the dissection.
Yes. Excellent. We'll stay with John Trahanis actually for the next one, which is if you have a scenario where...
Going back to the question that I asked at the beginning, what if you have a high line pressure before going on bypass after you cannulate? You know how as part of your checklist, they tell you the line is pulsatile and this and that and all that?
Yeah, so this is, I think, this scenario essentially where you want to make sure you don't have a dissection, but you also want to make sure that the line is positioned appropriately. And then also that they're checking you want to make sure that they're checking their arterial line measurements, that's also zeroed appropriately to make sure that they correlate.
Yeah, so before you go on bypass, if they just tell you that you have a high aortic cannula pressure, that may not mean anything, right? That just means that they're measuring central aortic pressure versus the radial pressure that you have up on the monitor. So that, you worry if your central aortic pressure is lower than your radial arterial pressure, but not necessarily higher.
The other way around.
Simply, flow some volume in and see what their line pressures are. And if they don't have a response, then you're good to go.
Got it. Great. John Trahanis, you are on bypass, things are going great, and then the arterial cannula falls out. What do you do?
I guess I have some unique knowledge of this situation. So it depends on where you are, what stage you are in the operation. So if you've taken the cross clamp off, or if you haven't clamped yet, if you've taken the clamp off, the patient has regained a rhythm and the function is good. In that situation, you can do kind of what Dr. Tolis was saying before, is you can give the volume back and just try to come off bypass once you've controlled the cannulation site and you're not hemorrhaging. If the arterial cannula comes out while you're cross-clamped, then that's a very different scenario because the heart is not going to be able to sustain the circulation, in which case you need to recannulate immediately by whatever means you can. And the first thing that you should do is just immediately snare. And don't forget that you have purse strings on the hole in the aorta to control the hemorrhage so that you can see what you're doing. And then either with the same cannula, once you've cut the tie, or with a new cannula, just recannulate the aorta.
John, on your first answer, which is correct, to try to give the volume back if the patient is warm and can support his own circulation. But how would you do that if the arterial cannulas come out?
Yeah, have them run the venous line retrograde.
I wish I had a perfusionist on this to tell us how easy it is to do that. One of the easiest things is actually just to take the arterial cannula and put it in the right atrium.
Sure.
It's pretty, they can flow up that venous cannula pretty quickly.
Hey guys, I'm here. Sorry, I had to move some AV equipment around. We have a bridge in our circuit that we double clamp it for the bypass run. But once we ensure the venous air is devoid of air on the venous line, we can flow retrograde at that very easily by moving a few clamps around in our circuit.
Okay.
And stop the pump, of course.
The other thing is when you're cross clamped and your cannula falls out, be sure that your vents are off so that you have at least some blood in the aorta. You don't want to put the cannula back in the aorta on an empty patient because then you have a high chance that you do have air. So you want to fill up the patient somehow.
Really important point.
Great. I know we're a little bit over time, but I have about a few more scenarios left that I was going to just finish up with. VFib after cross clamp is off. We can do Luis Tapias. What do you think about this one?
Well, it's important to know what the initial operation is, but it's my understanding is that it's not completely uncommon to have some ventricular fibrillation right after the clamp comes off from reperfusion. You can defibrillate the heart and see if you regain normal rhythm. And then again, if it's a cabbage, then you need to consider other differential diagnosis that you have there.
Great. Yeah, that's yeah, exactly. So it's a common item, and I've listed here. You want to use your internal paddles, set them to 10 to 20. Lidocaine, amio, all can be adjuncts to use. And then if you have other reasons, kind of as shown here, you can correct all of these. And that's kind of why we have some of the checklist items, including checking your electrolytes, checking your temperature, making sure you've aired. Yes?
One of the causes of this is just hypotension.
Hypotension.
So a lot of times you've just taken off the cross clamp, the pressure's 40, fibrillates. If you just drive the pressure up to 70 or so, the heart will defibrillate.
Great.
And then, Antonia, another reason why you cannot defibrillate when you try repeatedly is because your heart is distended. So a very important thing to do is, if you failed a couple of times, do a pump down for at least like 5-10 seconds and squeeze the volume out of the heart, and then
Okay, I think we lost Dr. Toulis there, but yes, point well taken. Thank you. Manually squeeze, empty it out, and then and see if you can come off of it.
Okay.
Massive air embolism. Jordan Bloom, what do you think? How will you manage this?
Didn't we do this one? So if you have a big air embolism, oh no, we did airlock, excuse me. So in this case, the first thing that you want to do is stop the bypass circuit. Obviously, that depends on where you are in the operation, but that's the key principle, is to stop bypass, clamp your arterial and venous. And then there are some other moves that you can do. If you have an SVC, if you're bicavally cannulated or it's aortic surgery and you were planning RCP, you can give retrograde cerebral perfusion, pump flow up the superior vena cava, and that will de-air the brain. You would probably want to do some start cooling in this scenario. Obviously, you're clamped, but cooling will protect the brain from air. And then, yeah, you've got it here, but there's some positioning, Stiefel-Tellenberg. I mean, people have talked about aspirating air from different sites.
Perfect. I think I like this setup where they have essentially, there's a perfusion kind of set of things to do, anesthesia, and then the surgeon for perfusion, you're going to tell them to stop, bypass, clamp the arterial and venous lines, de-air the circuit. And then for anesthesia, you can ask them to put the Stiefel-Tellenberg 100% oxygen, and then think about steroids and things like that, and then support the circulation with pressors. And then on our side, you can aspirate from air from the root, do retrograde brain perfusion, reinstitute, bypass, cold the patient with brain protection. And then all the de-airing maneuvers that we talked about, and then thinking about hyperbaric oxygen post-operatively is another component to think about.
You don't have this on there, but you know, people talk about aspirating the PA or the central line.
Mm-hmm. Yeah, I've seen that definitely on there as part of the options that you could do. You could add that. All right, to finish off with a couple more slides, Travis Hall, you have a hostile aorta, and by this I mean it's full of calcium. How can you manage this? Let's say you've opened up and you're ready to cannulate, but you just cannot find a spot that doesn't have calcium in it.
So if you're, I guess if you're doing a cabbage.
Let's say a cabbage, yes.
I guess you can try to do it off pump or cannulate non-centrally.
Excellent. Yeah, so try different cannulation strategy depending on what you're doing. Axillary, femoral, consider off pump procedure. And if you're doing valve surgery, you can try the procedure, for example, for mitral, so you could do hypothermia, fibrillating heart, HCA, or do a TAVR instead. Any other suggestions by the attendings in terms of managing the aorta that's not easily cannulatable? All right, we'll continue on to cold agglutinins. So I have these like very special case scenarios that I'm going to go through briefly. Cold agglutinins, this is an issue where patients have autoantibodies against surface antigens of erythrocytes that are activated during hypothermia. This is actually part of the perfusion checklist in terms of pre-oping the patient, making sure that the patient does not have any antibodies for this, and they do this with an assay as part of every case. The way you can manage that is by reducing IgM titers, or you could keep the core temperature warmer than the thermal amplitude of the autoantibody that the patient has. You should also make sure that all the IV fluids, blood products, and all the fluid is warmed for these types of patients. The next special case is sickle cell patients.
How do you arrest the heart for that patient, Antonia? Somebody who has cold agglutinins? You have to give cardioplegia cold, don't you?
I thought you could also give it warmed.
Or you could use crystalloid cardioplegia, right? You don't have to give blood.
Okay, great.
And if you give warm cardioplegia, it's either continuous or every 2 to 3 minutes. So you have breaks. Yeah.
The other thing is you may get some agglutination of red cells. You can actually see them visibly. The cardioplegia still works, and when you rewarm, they come apart. So you don't have to panic if you see that.
Okay. Great.
So if you get, the other thing is if you get report that there's a cold agglutinin, you got to ask the blood bank what the agglutination activation temperature is, because if I mean, it's less of an issue now because the contemporary heart surgery is not done as cold with as much systemic cold, but that can be a guide. You might have to use the cardioplegia at a tepid sort of thing. And you also have the extreme option of getting the patient the plasmapheresis beforehand.
Okay.
So you work with the blood
Would
bank.
would anyone here give cold crystalloid cardioplegia to someone with cold agglutinins? Cold
I've done it.
crystalloid?
Not a problem. Not a problem. And I've used the Daggett dilute blood stuff because you're diluting the agglutinin at the same time, and it's just not an issue.
George, why not?
I just would worry about the blood that is present in the heart when you give the cardioplegia, forming, I don't know if it's a critical mass, but there's already blood in the heart. So I'd worry that you'd get agglutination of that blood.
I wouldn't worry about it.
I don't know. No?
You can also do kind of an initial flush at a room temperature crystalloid and then cool it as the rest of the cardioplegia goes in.
So you could do a full operation like a cabbage with cold crystalloid cardioplegia.
Yes, it was done that way for years.
Yep.
No, I'm talking about my dad had his cabbage with cold crystalloid. I'm talking about someone with cold agglutinins. You wouldn't worry about any agglutination.
Not a problem.
Okay. I learned something.
I think you better be careful with that one on the boards. If that, I don't think that'll be on there, but I've avoided cold cardioplegia in the past at the recommendation
I would not do it.
Of colleagues.
I would not do it either.
Sounds good. Sickle cell patient is our second last special population group. For these types of patients, you want to think about pre-op blood exchange transfusions, plus minus hydroxyurea, and blood transfusions preoperatively to raise the hematocrit and lower the sickle hemoglobin levels. And then actually on the day of, before starting cardiopulmonary bypass, you can do exchange transfusions to reduce HbS levels and raise hemoglobin. And then the key here again is avoiding hypothermia by doing normothermic bypass and then giving warm cardioplegia or crystalloids only for these types of patients to avoid sickling during the bypass run.
Duke, did you have any sickle patients at Hopkins?
Quite a few. And I think Antonia's summary of the management is exactly right. That's exactly what we did, and we just used the crystalloid cardioplegia for that group as well.
Great. And then final scenario, pregnant patient. The things to think about here is number one, their volumes are larger, so you're going to have larger perfusion flows and pressures, higher arterial oxygen tension, and then aggressive management of the fetal circulation, especially preventing fetal bradycardia, and then use of tocolytic agents. And then one final point is about positioning, making sure that depending on what trimester they're in, that supine positioning can obstruct your venous drainage in the system. All right, and I think that should...
You maybe tested on that on the boards a little bit more. You also need to think about those in terms of either elective or emergency operations in patients with pregnancy.
Mm-hmm.
And one of the key things to ask for or determine early on is the fetus past the age of viability or not? You obviously need to get the OB people on board as well. If the patient is below the age of viability and this is an emergency, then you just take care of the patient. And with the understanding that the fetus is going to be at a high risk. If the fetus is beyond the age of viability, then you have the option of either delivering the baby at the same time as you're doing your operation, or in some way or form at the same setting. If this is an elective operation, then obviously they should all be deferred till at least the third trimester or till the time the patient can safely be in a period of pregnancy. I know Duke has. Duke, did you want to comment? I know you've talked about this in setting of marfans and dissection somewhat.
Yeah, I have really nothing more to add. I summarized here nicely.
The point is that fetal wastage is extremely high.
Yeah. Okay, great. This should have covered all of the objectives, and thank you everyone, especially the perfusion team, Dr. Melnichuk, for taking a lot of time to help me prepare these slides.
Antonia, you did a great job. I know it's a lot of material to cover, but you did a good job.
Thank you.
Well done.
Yep.
Thank you.
Great.
Well done.